All right, so type 3 hypersensitivity. So how does this compare to what we just talked about with type 2 hypersensitivity? Remember, in type 2 hypersensitivity, we have antibodies that are binding to the antigens on the surface of cells primarily. When we're talking about type 3 hypersensitivity though, these antibodies are binding to these kind of free-floating antigens or soluble antigens in the bloodstream. So the key word here is soluble. So we have antibodies that are binding to these soluble antigens. In other words, they're kind of just free-floating, and you can see these antibodies binding to them. Now in a type 2 hypersensitivity, we talked about these antibodies binding to antigens that were on the surface of cells, and the cell that we use as an example was a red blood cell. So instead of this antigen kind of free-floating, that antigen would have been on the surface of this red blood cell, and then our antibody would have bound to that specifically. Okay, and then that would have marked this red blood cell essentially for destruction. And that was what we talked about with the type 2 hypersensitivity. And again, type 3, these antigens are kind of free floating in the blood. And so, what's kind of the repercussions of that? Well, there's a couple things. You can imagine that if you have a bunch of these antibodies and antigens kind of getting stuck together, so to speak, and kind of forming that snowball effect where, that it's just going to get bigger and bigger and bigger and then get deposited into tissues. What happens here is you kind of see this arrow pointing down as this gets deposited into the endothelium here. As more and more of these antigen-antibody complexes get together, you're going to start to get complement activation on all of these FC portions of these antibodies. So complement is going to start to get activated, and we just kind of talked about that in the last video. What are the repercussions of that? Well, if it was a single cell, you'll see a lot of the membrane attack complex being released. But one thing you'll see, especially in the bloodstream here, when you have these immune complexes, is you'll get a lot of the C3, C4, C5a getting released. And when you think about type 3 hypersensitivity, think of this as being even a stronger level of complement response than you typically see in a type 2 hypersensitivity. And you might be saying, well, why is that? The reason is because you have all of these antigen antibody complexes together and all of these FC portions getting complement activation in this one location. So what happens with that? Well, remember, C3a, C4a, and C5a are all going to work to increase vascular permeability. That can lead to edema. So this is something that we've already kind of touched on, but the even more important thing is, remember, C5a specifically, we just talked about this in the last video, is responsible for neutrophil chemotaxis. That's particularly high yield, along with LTB4 and interleukin 8. So neutrophil chemotaxis to this site, you're going to get a whole bunch of neutrophils, right, from all of this complement activation. You're going to have all of this C5a. So you can see all of this kind of C5a, we'll just call it here, kind of getting released down into the bloodstream. And that's a chemokine. It's attracting all of these neutrophils to the scene, right? So these neutrophils are coming to the scene. And when these neutrophils get here, what are they going to do? They're going to dump tons of myeloperoxidase and peroxidase and just damage all of this tissue where these immune complexes are getting deposited. And this is on a pretty large scale in a lot of situations. So that you're going to have lysosomal destruction of that tissue. So this is essentially explaining the inflammation you get, right? When you talk about something like vasculitis, right? If I say, okay, this patient has, vasculitis secondary to type 3 hypersensitivity. What am I saying? Well, itis, right? We're just saying inflammation of the vessels. Where's that inflammation coming from? The neutrophils. Where's the neutrophils coming from? C5a. Where's the C5a coming from? Complement. And where's that complement binding to? They're binding to all of these antigen immune complexes. If you can kind of go through this in your mind, it's hard to get questions wrong because you understand the process, right? If you understand the process, you know how to play the rules of the game. You just have to apply that knowledge, just to apply the foundations. And that's essentially what we're talking about. So that's what vasculitis essentially comes from, right? So you have inflammation in the blood vessels secondary to this immune complex formation, right? And so the classic example of that would be polyarteritis nodosa, okay? And this is very classic for patients that have had hepatitis B infection in particular, and that's particularly high yield. And we'll talk about that more in the room section. Another classic one is post-strep glomerulonephritis, which is actually the most common cause of nephritis syndrome in children, okay? So it tends to get asked about very frequently. These patients will have all of this happening essentially in the kidney, and so they'll present with hematuria, edema, high blood pressure at some time after a strep infection. Usually 2 to 4 weeks is the normal range, right? 2 to 4 weeks after some kind of strep infection is very classic for causing this. And the classic strep infection that you should be familiar with is strep pyogenes, right? That's going to be very, very high yield to remember. And we'll talk about this more in the renal section. But again, it's applying that knowledge to understand the pathophysiology. That's where a lot of the questions come in. Lupus, it's the same thing. Again, we're targeting the kidneys in this situation. That's our tissue, IgA nephropathy, all of these being kind of that same category. And then hypersensitivity pneumonitis is also in here. Okay, and again, the point of this video, though, is not so much to go through each of these diseases, but more so to understand this mechanism. Again, antigens are binding to immunoglobulins, soluble antigens, floating around in the blood, not on any tissue at this point. Then they're forming these immune complexes like we see here. Those immune complexes are then getting deposited into tissues. If it deposits in a blood vessel, I get a vasculitis. If it deposits in a joint, I get an arthritis, right? If it deposits in a kidney, I get a nephritis. Now, the thing that I said earlier is the complement activation is quite extreme, especially compared to the type 2 hypersensitivity. And the thing that you want to remember about that is the neutrophils are really mediating a lot of the damage here, okay? Because there's so much immune complex formation, there's so many FC portions kind of localized in that one location, you're getting a lot of neutrophils to one spot, and they're all kind of just dumping their myeloperoxidase, peroxidase, all these toxic substances onto the host tissue. Okay, so we kind of already touched on this, correlating with the tissue involved. Now, one image that I think is relatively high yield is just understanding, when you get a patient that has vasculitis, as this is kind of the classic type 3 hypersensitivity along with some of these nephritic syndromes, it's important to understand kind of what you're looking at. Okay, so when you're looking at this slide here, I can see that this is a blood vessel, right? So I can see that I have a blood vessel here. I can see it's got kind of a muscular outer wall here, right? So probably arterial. And then you can see all of these red blood cells in the middle here. So that tells me this is some vessel. And if we go zoom in a little bit, we can see kind of the outside of that vessel. You can see all of your red blood cells are here, right? You have all of your red blood cells, okay? And then you can see there's also a bunch of neutrophils in here. So we have a lot of inflammatory cells that look like they're inside this vessel. And then you can kind of see that here too, right? In this vessel, here's your muscular lumen, right? You see your red blood cells here, and you can see that there's a huge inflammatory infiltrate here. And so when you see something kind of similar to this, where you see a lot of, and the easiest thing to do is just to look for inflammatory cells. The inflammatory cells everywhere is going to be significant in patients that have some type of inflammation ongoing. A lot of times you'll see the inflammation in vasculitis described when they're looking at the blood vessels as a fibrinoid necrosis. This vasculitis in particular, the other thing to know is, again, because it's mediated primarily by leukocytes, right? It's mediated by white blood cells like neutrophils. Sometimes this vasculitis in particular, when we're talking about this, is called a leukocytoclastic vasculitis. So what they're essentially saying is it's a vasculitis that's primarily mediated by leukocytes, right? And so that's the concept. So that's when you see leukocytoclastic vasculitis, fibrinoid necrosis. These are all kind of big words, kind of scary words if you don't know what they mean, but they're really just talking about a vasculitis induced by the leukocytes because of the complement activation, right? And then also you have a huge inflammatory infiltrate. You have necrosis of this tissue because you're dumping all this toxic substance onto the lumen, essentially, right? Or the blood vessel wall, and that's causing you to have some necrosis. So serum sickness is also very classically talked about with type 3 hypersensitivity. Now, let me just kind of clean this up a little bit so I can tell you a little bit about this. Okay, so when we're talking about serum sickness, the classic kind of way this is going to get asked about is usually with antitoxin or antivenom. So let's just say that we have a patient that gets bitten by, and this is supposed to be a rattlesnake, okay? So this rattlesnake is essentially going to, inject some type of antigen, right, into this patient that's essentially going to cause an inflammatory response. Okay, and we want to give this patient an antitoxin to that antigen, right? So what this patient does is they come to the emergency room and they have symptoms, etc., and then we give them the antitoxin to that rattlesnake, for example. Okay, so we give them the antitoxin, and this antitoxin is essentially going to be binding up to these antigens, right? And in some way, depending on what we're talking about specifically, if it's rattlesnake or tetanus, it's essentially going to eliminate that antigen from causing disease. And it could do this in a variety of ways. Again, this is gross oversimplification. But the concept is we give them an antitoxin. Now, the patient may, in some situations, create antibodies to the antitoxin. So the patient might say, look, this antitoxin is foreign to me. I don't recognize this antitoxin. So the body might start to make antibodies, right? So the plasma cells eventually will get wind of this and they'll start pumping out antibodies to the antitoxin. So these antibodies will try to bind to the FC portion of the antitoxin. So again, this is where you have to kind of be sharp on the name here. We're making antitoxin antibodies, essentially, right? For the plasma cells to start pumping out IgG antibodies, for example, to the antitoxin, we have to go through class switching, right? There's a lot of steps in the pathway, right? The antigen presenting cell goes to a T cell binds CD40 ligand, class switching, etc. All the things that we talked about already. So this process takes some time. So the first time this patient is bitten by a rattlesnake and they get antitoxin, we're not going to see this happen, right? We're not going to see this happen because it takes time. It's going to be on the subsequent exposure. If this patient gets bitten by a rattlesnake again, okay, so now they get bitten by the rattlesnake a second time. Okay, so I'm going to put times 2 here. Now they get bitten again. And if we give this patient the antitoxin a second time, right? So now I give them the antitoxin times 2. This is the second time. Now we already have these preformed antibodies. We have a memory response because there was some initial exposure. So now guess what? Now we have a whole bunch of these antibodies around to bind up these antitoxins. And so what does that do? Well, now you have, if you can imagine this, you have an antitoxin that's bound to the antigen, and you also have the antitoxin antibody all bound in one structure. And so, of course, these are going to start to kind of congregate, and you get what? You get immune complex formation, which is the classic thing that we're talking about with type 3 hypersensitivity. And this can happen throughout the body. Okay, so again, just reading through this, we have antitoxin, antivenom antibodies, and the other ones that are very classic for this are the monoclonal antibodies. These are going to be very classically recognized as foreign. Remember, these are going to end in MOB, right? Those are the monoclonal antibodies. A board question in some situation can ask you about a patient that recently received one of these and now has immune complex formation, or now has vasculitis, or arthritis, or glomerulonephritis potentially from exposure to either monoclonal antibodies or antitoxin antivenom, usually after multiple exposures. Now, if somebody's taking a monoclonal antibody for 6 months, then of course, yes, they can eventually have serum sickness because they're constantly being exposed to it. But with antitoxin antivenom, usually it's on subsequent exposures. Now, what can you test for? And this goes for all of type 3 hypersensitivity. What you can test for C3, C4 levels. And you might be saying, well, why is that? The whole crux behind this type 3 hypersensitivity is that you have widespread, massive amounts of complement activation. And if you have massive complement activation, significantly higher than a type 2 hypersensitivity, you would expect your complement levels to be low in the serum because you're using up a lot of that complement. Now, of course, you might be saying, well, what am I going to look for on pathology, for example, if I have a patient with serum sickness? Well, we already talked about it. You're going to look for vasculitis. You're going to look for arthritis, glomerulonephritis. You're going to look for tissues generally that have immune complex formation that are getting damaged, some kind of inflammation. And a lot of times this could be systemic because these antibodies are traveling everywhere in the bloodstream, depositing everywhere. The thing that you have to be careful about is serum sickness-like reaction, because occasionally this gets distinguished from serum sickness, since this is not the same thing. The big thing to remember is that serum sickness-like reaction is not considered to be a type 3 hypersensitivity. Okay, so it is not in this category. Serum sickness is considered to be a type 3 hypersensitivity. Serum sickness-like reaction is not. And there is no immune complex formation, which is essentially why it's not considered to be type 3 hypersensitivity. And the idea here is that this presents similarly to serum sickness, but because there's no immune complex formation, generally the symptoms are much milder and the complement levels are normal because complement is not causing the symptoms per se. This just has a similar presentation. So it's a different mechanism, different pathophysiology. It just presents similarly, less severe, normal complement. Classically, penicillins and cephalosporins are kind of notorious for kind of getting in this category. Now, of course, you can take penicillin and have a type 2 hypersensitivity, right? We kind of already touched on that. This isn't saying that penicillin only causes serum sickness-like reactions. This is just a very classic presentation. So if you start to get a patient that has a little bit of arthropathy, maybe they have some hematuria, but they have normal complement levels, no immune complex formation, and they're bringing up penicillin or cephalosporins that the patient was recently started on, it would be a tougher question, but you would probably want to start to think about serum sickness-like reaction, especially if they did some biopsy and there wasn't really an inflammatory infiltrate, right? All right, the last one on here is going to be the Arthus reaction, and this is probably the least high yield of the ones above, but it is something that comes up occasionally, very classic as a complication of the Tdap vaccine. And this is essentially talking about a more local immune complex formation. So remember, with serum sickness, this is everywhere. This is in the blood. We gave that antitoxin, right, systemically into the bloodstream. Whereas with an Arthus reaction, you're injecting usually in one area, and so you have a local reaction just in that area where you have immune complex formation. And what happens is, initially, again, just like with the antitoxin, the first time you give the vaccine, the body might make some antibodies to it. And with Tdap, right, or DTaP, starting in the younger population, what happens is over time, you're constantly exposed to that vaccine because you need a lot of boosters, right? And so over time, you make antibodies, right, to those Tdap antigens. And so eventually, as you get the vaccine, right, what's going to happen is you get this kind of local reaction. You might get local, swelling. You might have a little bit of complement activation in that one area, a little bit of inflammation in that one area, but overall, significantly less severe than what we're talking about with something like serum sickness. And again, this is going to be very classic as a complication of a vaccine that requires a lot of boosters. Tdap tends to be the classic